Next, we have Dr. Vardhaman Kankariya with his cases.
Hello. Hello. Yes. Hi. I'm just going to take you through two small cases, and actually, to keep it slightly different, I have chosen extreme scenarios. I think this is for most once in a lifetime situation. I had pleasure of taking care of both these patients as well as operating on them during my fellowship with Professor Palikaris. So this was a 23-year-old female who came with a history of uneventful bilateral LASIK procedure. Basically, she had a history of worsening keratitis 1 month after the primary procedure was performed. Her primary procedure also involved a secondary setting of flap reposition, which was done in the left eye about a day after the primary procedures. And she developed symptoms almost 11 days after the LASIK. Corneal scraping was done at the primary center, and it had actually confirmed that it is an atypical mycobacteria, which, as we all know, is the most common post-LASIK infection. And she was put on oral doxycycline by the primary surgeon with topical fortified amikacin and moxifloxacin. So this was the picture at presentation. So as you can see, her vision was very bad. The vision was hardly finger counting. The slit lamp showed presence of multiple infiltrates in the interface, and they were also involving the flap as well as the interface, and there was a bit of flap melt which was seen. Basically, the microbiology was repeated again just to confirm, and it again showed atypical mycobacterial keratitis. The medical treatment was continued, and then oral clarithromycin and topical fortified amikacins were added along with moxifloxacin as per the ASCRS white paper protocols. And even after 7 days of treatment, the patient actually continued to worsen. And basically, now the question was, what next? So probably I would like to ask Cordelia about this case. How will you manage if this is the scenario?
Yeah, can you go back one slide? Okay, actually for atypical mycobacterial keratitis, it's always a difficult and challenging problem. In this case, you tried medical therapy. Okay, so next slide. Based on your choice of antibiotics, I think you've covered almost everything. In this case, have you considered lifting the flap and irrigating?
The flap melt was already there. So basically, the flap had already started to melt. So basically, then that's the reason that we didn't think about lifting the flap and then probably continuing the treatment.
So what is the status of the
So basically, the next line of treatment that what we were thinking about, like this is almost 5 years ago, was of course doing a therapeutic transplant for this patient because he was refractory keratitis. So basically, when we were waiting for the graft that time to come.
Can I interrupt? Yeah. How deep was the infection?
So this was almost till mid-stroma.
Because in a case like this, the last thing you want to do is actually to enter the anterior chamber, because you're talking about a atypical mycobacterial keratitis in a LASIK flap, okay? So it's involving the anterior part of the cornea. So why are you jumping into a therapeutic PKP?
So basically,
at this point, I would maybe do a flap amputation at worst, rather than to do a PKP. Okay,
so that sounds a fair approach as well. So that would have probably also been one of the approaches. But for example, in this case, then the next line of treatment, what we had thought about was probably going for a therapeutic transplant. And so basically, when we were waiting for the graft, we spoke with the patient that probably a chance of collagen cross-linkage can be done, and this is in 2011. So basically, the cross-linking and its efficacy that we know in bacterial infections now was not so evident that time. So we had a small discussion with the patient. We took a written consent from the patient, and then basically this is what exactly we did. We amputated the flap because anyway it was melted, and it also improves your penetration of your antimicrobial profile, and a standard resident protocol CXL was performed. And this is how the patient behaved afterwards. Like there was a immediate symptomatic improvement after the cross-linking was performed. It took almost 2 to 3 weeks for the keratitis to resolve almost completely. The epithelialization was actually better than what we were expecting, and because of the flap amputation, because I think it also could have been very deterrent to the optical effects when we did that, the vision that the patient achieved was almost 20/35, 20/40, which was, I mean, better than our expectations in this scenario. So we know that Dr. Mukesh has done a lot of work in collagen cross-linkage in infections. So I would like to ask him about basically his work about comparing the riboflavin cross-linking protocols versus the new dye that he is working with.
We basically analyzed the riboflavin cross-linking with rose Bengal cross-linking.
Right.
And we tested it for bacteria. Both works beautifully for bacteria, rose Bengal as well as the riboflavin. And the rose Bengal also works for the fungal. And in clinical settings, it was also shown to be working for acanthamoeba. Unfortunately, we did not try that for atypical mycobacterium. That is one thing. So I have nothing against trying it. Yes, that's a good way of moving ahead.
Right.
My question would be, you say after 7 days of treatment it was not responding. I have not seen that picture, so how do you say that one, it did not respond?
No, unfortunately I
Second,
don't.
Second,
Yeah.
I want to know, when after you did collagen cross-linking, was the patient still on treatment?
He
In the
was
sen-
on treatment, yes.
Okay, so
The
it
treatment was continued along with cross-linking was done, so it was add-on. We did not, it was not a CXL alone approach, it was combination with antimicrobial.
Our experience so far tells us that it probably is a good adjunctive tool for bacterial keratitis.
I think that's extremely important. I think what Dr. Mukesh has told is extremely important, because I think there is a lot of buzz right now to use CXL as a primary alone approach as well, which is, I think, I really wanted Professor Hafezdi to be there for this. But currently, till the time we have the further evidence, we should always combine it with the antimicrobial agents, and that is how it will really work very well.
Another thing which you have done is you have amputated the flap, so that would also have taken some bit of a load of mycobacterium away.
Yeah.
So that is also a factor. So there are quite a few things which are working here. One of the factor is collagen cross-linking.
Absolutely, absolutely. I absolutely agree. So basically, I would like to also ask you, Dr. Mukesh, how about the fungal and acanthamoeba success? Because most of the literature says that the cross-linking works very well, especially on bacterial organisms, but not so well on acanthamoeba as well as on fungus. So any experience with that?
The riboflavin collagen cross-linking does not, I mean, it's not collagen cross-linking. Riboflavin cross-linking, in our experience, did not work for fungus.
Yes.
We did that for the culture plates also. The rose Bengal did have a very good effect. Rose Bengal with the green irradiation, green color irradiation, had a very good effect for fungus. Acanthamoeba, again, we did not find very good results in the lab, but the study which is being carried out and still continuing, we did that when I was at Bascom Palmer.
Yes.
And Amaskua has continuing doing that study, and he has about 3 cases of acanthamoeba keratitis, where he found very good results with rose Bengal. And I've seen those pictures where it has been very effective. But I was not able to get those results in the lab for acanthamoeba.
So the last question, Dr. Mukesh, is
you also
basically
tried that in
in which patients you would really have the possible use of collagen cross-linkage, like whenever a patient walks in to any of our clinics today and has keratitis, when would you actually think about doing a cross-linking adjuvant treatment along with my antimicrobial therapy?
First and foremost, you have to understand this is basically an optical treatment.
Yes.
Okay, it's basically dependent on the light penetration. So if you have a dense infiltrate which is very deep, it is not going to penetrate deep. So basically it will work for the superficial early cases of keratitis. And those cases, if they are bacterial, they also respond to your medical treatment. It doesn't really have a very good rule for the bacterial keratitis. But early cases of fungal keratitis probably would be a good candidate with the rose Bengal cross-linking.
Absolutely. All right. So basically, as I think Dr. Mukesh has said, these are basically currently advisable only for the refractive keratitis, and the cases in which microbial and culture like conclusions are not really conclusive, if there are multiple co-infections and if there is associated corneal melting. So we happened to publish this paper in 2012 in JCRS that time. So this is another quick case. So basically, Dr. Chitra ma'am has already discussed about post-smile epithelial ingrowth. We all know how to manage epithelial ingrowth in LASIK scenario. So this is about a case he was a 35-year-old female patient referred to our department due to severe post-epithelial ingrowth. As you can see very nicely that there are like this necrotic cells which are there, as well as they are even melting the flap. The flap has already set in, and the primary center has already done what typically can be done for this. The flap was lifted, scraping was done, alcohol was used, mitomycin was used. The next time they lifted the flap, did everything else, put the sutures again. So instead of the glue, that time they put the sutures. But in this scenario, when the situation is actually really bad, what would you really do? I think, Damien, if there is anything you can add. Yeah.
Yeah, that's a very challenging situation. So I suspect, yes, there's a lot of astigmatism there.
Yes.
So how many, 2 previous attempts, yeah. So I think I would try, of course, again to get rid of this in growth. Specific measures you can do, and which I've done with relative success, is that, of course, you have to scrape both the stromal surface and the back flap surface extensively.
Right.
Maybe also remove a little epithelial layer outside the flap. The additional measures I do now is sometimes do some excimer laser, like I do like a 1 millimeter spot, and I just do laser on the edge, on the stromal and on the back flap surface side, just on the edge. The idea is to promote some fibrosis, although fibrosis takes time, but still to make also maybe the flap edge more regular, or remove sometimes some fibrosis, which may prevent from a nice healing. You can use tissue glue.
Yeah.
But what I do usually, I have done that to save tissue glue. I just take a little blood from the conjunctiva with like a little needle, and then I put it in the groove at the edge of the flap once it's back.
Right.
And of course, bandage lens for the longest you can.
Right. But in this case, I mean, this approach would have been really nice. But in this case, because we have a flap melt already which has started to set in, would your approach change because of that?
I would give a chance to try, because if you
I think
fail,
Professor
then
Bellin,
you can
if
still
there is
remove
anything
it.
that you can
I
add.
would do exactly what you did. I mean, if you found out when you're trying to lift the flap that's not viable, that's totally different. You can truncate it. The only thing I would do in addition, probably, I agree, you really need to retract the epithelium off the wound. That I would consider putting some amniotic membrane, which will melt in a few days, but you really want to get the epithelium to heal in as quickly as it can over, as opposed to doing a slow growth that may go back in.
So I'll just show you the next picture. This is the topography of this patient. So basically, as you can see, because of the flap melt which has set in, look at the flattening that it has created. It is unbelievable. It has gone to almost 27 diopters. So this just tells us what is the impact of this thing. So what we decided to do in this case,
it could be not melt, you don't know, it could be also the volume effect of the epithelium, because in many cases you see this and there's no flap melt also.
I agree, and that was there itself, like there was a volume deficiency effect, as well as there was a flap melting which was seen on the slit lamp. So yes, I think that's a very valid point. So basically what we decided to do, because I think all these approaches that we have discussed, they were already done, and because of the flap melt which was already there, so we actually decided to get rid of the flap itself, and we actually had to do, this is again for everybody's benefit, this is an extreme situation. I think this is something which is probably once in a lifetime situation to like treat this patient with such a, let's say, aggressive way, but in this case nothing else would really work. So the only way that you can go about it is going around, and then you lift the flap. You can actually see a bit of flap melting, if at all. Like this is not so easy to appreciate, but maybe. So you can see those epithelial nest cells and the necrotic stratified epithelium which is actually causing all these issues. So once the flap is lifted, you have to actually So this is the flap amputation that we are doing, and of course, as Dr. Damien has told, we are going to scrape the epithelium after that as well from the stromal side, just to get this surface very, very regular. The second point which was important was to use a bit of eczema laser PTK for 10 microns, just to have a slight smoothness with use of BSS as the masking agent in this case. So this is what is being done, and then use of a bit of mitomycin C and then the contact lenses at the end. So basically this is how the patient did. So this is the patient's pre-op and this is the post-op. As you can see, this is almost I think couple of months after the procedure, and the patient actually improved beautifully to almost 20/40 vision from a seemingly uncontrollable situation. So here my question is actually what can be done, because most of the reasons for the flap ingrowths are during the flap lifts when we do enhancements. So are there any pearls that you would like to share so that the chances decrease?
I don't lift flaps when I do enhancements. I do them on the surface.
Okay, you use surface ablation only for enhancements. So what about?
I don't think I've had an enhancement over 3/4 of a diopter in 5 years. I just do them on the surface.
Which makes sense.
And I've never had never, you never say never, but I don't routinely use mitomycin on that shallow of an ablation.
Right.
I know, historically, the literature suggested post-LASIK PRK was contraindicated. I think that's no longer been shown true.
Right. Anybody is lifting flaps for surface ablation? I think Dr. Ramurthy sir was here. I think he has gone to catch the flight. So I think we'll stop with that, and I would like to thank NN for great time. I think both in the halls and the fun that we had yesterday. I think it was a great show. Congratulations to NN team, and thank you very much for all the kind of hospitality. Thank you.